and good afternoon to others who are on the other side from Arizona. Welcome to this insightful conversation during Breast Cancer Awareness Month, to our breast cancer conversation. Today, we are privileged to have three distinguished speakers with us, two Mayo Clinic doctors and one courageous breast cancer survivor, Dr. Sarah James, who's a radiation oncologist here at Mayo Clinic in Arizona, and Dr. Lita Mina, a breast medical oncologist also here with us at Mayo Clinic, Arizona, and Ms. Von Schell Offord, who is joining us from the sunny state of Florida. So together, we will delve into a conversation on two aspects of breast cancer care, radiation and hormonal therapy, and additionally shed light on the latest updates in breast cancer guidelines, screening guidelines, empowering you with the knowledge to make informed decisions for your health. So get comfortable and let's explore these topics together. We'll begin with Dr. Sarah James, followed by Dr. Mina, and then you'll hear from Von Schell to share her journey with you all.
So it's such a privilege to be able to speak with you all today, and thank you for taking some time to join us for this important conversation and nicely during Breast Cancer Awareness Month. As you're probably aware, breast cancer is a very common disease. So our latest statistics would say that your risk of developing it in your lifetime is about 1 in 8, or somewhere between 12 and 13%. So the odds of either being directly impacted by breast cancer or knowing someone who is quite high. Now, the incidence of breast cancer has been increasing over recent decades, but nicely, the mortality or death rate from breast cancer has been steadily decreasing over the same time period. Now, the reason for that is because of breast cancer screening. So there's absolutely evidence that this has saved lives since the implementation of screening mammography in the late 1980s, which is why it's so important for us to know about how to approach this for ourselves in our communities. So we still standardly use mammogram imaging of the breast for screening. There are multiple different guidelines that are available from different societies and specialty groups. And most guidelines have historically used kind of age-based population statistics about breast cancer and risk of mortality or death to kind of help guide the recommendations. But these are continually updated as we get more and more information on breast cancer outcomes to try to make sure that we're doing a better job or a good job at detecting breast cancers early, because they're so very curable. And so modernly, there's an important emphasis on making sure that you have some idea of your breast cancer risk in order to help guide you with your screening options. So there has been a little bit of discrepancies between different guidelines about the younger age group population, so women in their 40s specifically, of whether or not average risk or kind of baseline risk patients should be started at that age or not. However, our data was indicating that these very people are the ones that you can really spare years of life lost if you're detecting their cancers early. So Mayo Clinic screening recommendation is that you should have a risk assessment by the age of 30, especially if you're of African descent or Ashkenazi Jewish. And that is because of an increase of younger women in those populations presenting with breast cancer. And if you're determined to be high risk by this assessment, then you should consider a consultation in a high risk breast clinic to determine ways that you can reduce your risk and ways that you should approach your screening. And we continue to offer screening for average risk patients starting at 40 with the option for yearly screening. And so this is just a very busy slide, but basically the kind of most up-to-date NCCN guidelines for screening really indicate this, that there should be a clinical encounter where you're meeting with a provider, discussing and assessing your breast cancer risk. And importantly, and I wanted to emphasize that screening is not if you are symptomatic. If you have changes in your breast that you can note, whether you can feel a lump or you start to have a discharge, notice skin changes that are different and new, those are symptoms that need to be evaluated and diagnosed. So that is not screening, and that should happen whether you're 18 or whether you're 80, that you should go and have diagnostic imaging and clinical evaluation. But for average risk persons, but between the ages of 25 and 40, you need that assessment, and you should be have some breast awareness regimen or routine where you're familiar and aware of your breast and the changes to your breast. And then over the age of 40, also adding in the screening, the annual screening with mammogram, 3D, or with tomosynthesis is the category 1 or the highest level recommendation for screening. And then if you have dense breast, and that is something that is noted on your mammograms, it's not how your breasts look or feel, then you do need to consider whether or not you may need some additional types of screening or what should be done in your circumstance. And then higher risk, a lot of that determination is by family history, but basically any uh, 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 combination of things that would increase your risk over about 20%. So remember, baseline risk is somewhere between 12 and 13. But if you have a greater than 20% lifetime risk, then certainly be evaluated by a high-risk clinic, determine how that affects your screening. And if you have a significant family medical history, you may be referred for genetic counseling and potentially genetic testing. Now, breast cancer is still very much a surgical disease, and so that is the primary mode of treatment is taking out the disease. Most patients are treated with a lumpectomy surgery, where it's just the removal of the tumor with a bit of margin around it. And we do also check the lymph nodes for invasive disease to make sure that the main draining lymph nodes are not involved with disease. And then for some patients, either because their disease can't be completely removed with the smaller surgery, or if they wish to do it for a recurrence risk reduction, or personal reasons, you can have a mastectomy surgery with removal of the breast tissue, and lymph nodes are still evaluated in the setting of invasive disease. And so then we know that there are lots of things that may impact or do impact your risk of your disease recurring after surgery. So some factors that we've been aware of for quite some time, whether it's age, race, size, the grade of your disease, the hormone receptor status, those factors. But what we more modernly know is a large factor for your recurrence risk and overall risk from the disease is the biology of the disease. And so our modern approach is to take a look at the biology of your breast tumor and determine and use that. And we're able to now better approach individual breast cancers based on risk and where we need to escalate therapy, add therapies to reduce that recurrence risk, we do. And in a lot of situations, we actually can determine that your risk may not be very high. And then we're able to take our foot off of the gas and de-escalate therapies and still maintain a very appropriate recurrence risk. And so, in the setting of radiation treatment, which is one of the we call them adjuvant therapies, but outback therapies after breast cancer. We try to minimize our treatment volumes as much as possible. And also, if we can reduce time and toxicity, certainly that's one of our indications. So now I'll talk specifically about radiation therapy, which is my specialty of practice. And so, one of the questions that a lot of people have is just what is radiation treatment? Certainly, when I was still a layperson and even getting some medical knowledge, it wasn't really clear. But it is the use of high energy X-rays, which are photons, or particles, and using those beams to treat cancer. And so the radiation causes damage to the DNA of cells, and that's how it has its effect. Now, the majority of cancer patients are treated with radiation, and it can either be as a curative approach to keep you cancer free, or if you are not a curative patient, it can help alleviate symptoms and issues from your disease. So, in the setting of breast cancer, radiation is typically very focused at the area at risk of recurrence. And modern day, we have very rigorous quality assurance of our radiation treatments. And so it's an extremely safe treatment method. And so, for the majority of patients that are just having the lumpectomy surgery, so breast conservation, pretty much the standard for most is whole breast radiation. So the affected breast is treated with radiation treatment. And back when I initially started my training, the standard was to do that in 5+ weeks of daily radiation treatment. We call them fractions. But basically, we know that we have to give a certain dose in total of radiation to eradicate any potential residual disease. And we give them in small doses day by day. And we still have good effect at getting rid of any leftover cancer cells, but it gives your normal body time to recover from radiation treatment and repair that damage. However, that 5+ weeks of radiation is not routinely recommended anymore. There are still some circumstances where we do that, very advanced disease like inflammatory breast cancer, or for very young patients, we might still do that because of not having a lot of data with some of our newer approaches. But definitely nationally, more of the standard is to do, we call it hypofractionated, where we're actually just using larger doses day by day, splitting this over 3 weeks, and overall giving less radiation. So patients do very, very well with that. And then something that is emerging and that we also offer here at Mayo is 5 daily radiation treatments to the area. So there isn't any kind of standardized guidelines or practice guidelines yet. So data is maturing with this, but certainly something that can be considered for a large number of patients. And then another very good option is partial breast radiation, where, again, these are well-selected patients, so a certain subset of patients, certain age, small tumors, importantly, no involved nodes and no residual margin of disease after surgery. And you can just target the lumpectomy cavity and not the whole breast. And you can do that in 3 to 5 treatments. And again, something that is very well tolerated by patients and pretty convenient. And then intraoperative radiation, where radiation is applied at the time of surgery, is something that has been done in the past, but it's not recommended currently. And then many patients also are candidates to consider not having radiation treatment. And these are well-selected patients with very favorable characteristics, typically older patients as well, that your baseline risk that you're starting out with is pretty low in the beginning. And so you have the option that even though radiation is going to reduce your risk of recurrence, if it's starting out at such a reasonable level, you have the consideration of not doing it. And then for people that have had a mastectomy, we typically recommend radiation if it's a large tumor, if lymph nodes were involved, if you still had a positive margin from the tumor. And those treatments are still done in at least 3 weeks. There are still ongoing studies to see if there can be any differences in that approach. And then importantly, people want to know about side effects because it can be scary. Again, radiation can be a bit abstract if you haven't had any experience with it through family members or friends, but very well tolerated treatment. Pretty common for patients to have some fatigue, some dermatitis, and that's what we call skin irritation. But the significance of that is much lower in modern times with how we give radiation and how we plan radiation. And a list of side effects that we talk to you about, but are quite unlikely for the majority of our patients. Importantly, though, one of the significant things that we do is take great care in planning to reduce dose to your heart if you have left-sided disease that's being treated. So we have all sorts of techniques and tips and tricks that we use, one of which is called deep inspiration breath holding, where we ask you to take in a deep breath, hold it, pushes your heart back and away from your chest wall. And it allows us to cheat your anatomy and give radiation safely without impacting your heart. Some patients are candidates for prone positioning. So most of our treatments are done with you laying on your back on what's like a CT scanner table. And if we're not needing to treat lymph nodes, we can actually plan to treat you with you laying on your belly and your breast is pulled forward and away from your chest. And so usually we're able to give radiation without impacting, certainly not your heart and off of your lungs. And it's a really nice way of protecting adjacent tissue. And then lastly, here at Mayo, Arizona, we have proton technology, which is a charged particle beam. And with that, we can be very specific in how we're giving the radiation. And so for some people where we're having to treat large volumes and having to treat right directly next to the heart, and our other processes for planning don't quite do a good job, we have that as a way that we can spare adjacent tissue. And this, we also use it for partial breast treatment. So this is the dose on a scan. So you can see we can very focus the radiation on the lumpectomy cavity and avoid treating the rest of the breast and the rest of your body. So we have a very nice video in coordination with ASTRO, which is our Radiation Oncology Society, that has a 30-minute video that goes through radiation in a lot of detail. And then if you need more information, there's rtanswers.org, which also has lots of brochures and information for your review. And so certainly I like talking about radiation and love what I do. But now I'm very excited for you guys to hear from Dr. Mina, who's one of my colleagues who is our counterpart and sees most of the breast patient and discusses all sorts of other therapies. So Dr. Mina.
Good afternoon and good morning, everyone. It's hard to follow Dr. James. I don't have specific slides, but I was going to give an overview a little bit on endocrine therapy. Although this is not the only type of therapy we do, but that's going to be our focus. So what I will start with is 3 common myths that we hear all around. And the number 1 myth that we hear is basically endocrine therapy is chemotherapy. So I would like to kind of shed light on this first information by saying endocrine therapy is not chemotherapy. So in general, when we're talking about chemotherapy, it's basically attacking, dividing cancer cells. And maybe that's kind of something that endocrine therapy helps do. However, endocrine therapy is more of a targeted treatment, going specifically for cancer cells that are estrogen driven, and is very different than giving chemotherapy. So that's number 1. Number 2 is basically chemotherapy in general works better. And if I do chemotherapy, then likely I don't need endocrine treatment. Again, this is a second myth because each type of treatment has its own indications. So in general, like Dr. James has mentioned, I mean, breast cancer is such a common disease. More than 80% of breast cancer is actually estrogen driven. And if that cancer is feeding on estrogen, we are usually trying to target that pathway and give targeted treatment instead of giving chemotherapy that would kill any dividing cancer cell. So that's kind of the second myth. And the third myth is postmenopausal women do not have any estrogen. And that's something that's not true. And even if ovaries are suppressed, not working, even if a woman is postmenopausal, the number 1 breast cancer that she tends to have is still the estrogen driven. And the number 1 treatment for this type of cancer remains estrogen blockade. So having said all of that, we do usually approach any type of breast cancer by a collaboration between what we call local treatment as well as systemic treatment. So local treatment is a part of what Dr. James does, which is trying to treat the tumor. Usually we have surgery, do the resection, then Dr. James helps with getting the radiation, like she eloquently kind of explained, trying to safely protect the rest of the body. And then the second part, which is the systemic part, is this is when endocrine therapy is very important to basically prevent cancer from coming back somewhere else in the body. And endocrine therapy or anti-estrogen therapy there are many medications within this group. And I think for every breast cancer patient or every patient who's maybe just at high risk, it's very important to understand their actual risk so that they can understand what's going to be the benefit as well as the risk from any type of therapy, and specifically endocrine therapy. So when we talk about endocrine therapy in women who actually do not have cancer, those are patients who may be at high risk, even patients who actually have what we call precancerous lesions. In that group of women, we know that endocrine therapy is actually helping with prevention. So it's more of a preventive approach to help them decrease the risk of getting invasive cancer in the future. Whereas when we're approaching women who actually have cancer that is estrogen driven, this is when giving endocrine therapy or anti-estrogen therapy can be life-saving. And this is what we have to discuss with each patient, what's actually the risk and what's going to be actually the benefit of taking those medications. So the general kind of approach to cancer patients who actually have estrogen driven is a double thing, where basically this is a disease because it feeds on estrogen. It tends to be slow growing. So I think a lot of information, a lot of it is important to tell the patient that this is unfortunately in a lot of scenarios more of a chronic disease, more so than an acute, life-threatening acutely. So that's why we try and approach it not only from the acute setting, this cancer happened, but also with a view of a lifelong risk of this cancer possibly coming back. And whenever this is estrogen driven, it is something that we're trying to focus on to make sure that this cancer doesn't come back a year, 2, 5, or even 10 years from now. So it is usually a journey. And here at Mayo, even if you've had your surgery done, and we tend to follow our patients long term to make sure that they are able to tolerate the treatment, they are able to handle the side effects, and making sure that they're not dealing with a late recurrence. Having said that, as we all know, endocrine therapy has a lot of side effects. And those side effects in general can start improving, but initially it is going to be important to talk with a provider, with all the staff, to kind of make sure that you're able to tolerate the medication. Those medication, by blocking estrogen, they have two ways of working, either working through blocking receptors on the cancer cells or blocking the formation of estrogen altogether. And as you all know, we all love our estrogen. We all actually, once we're hitting menopause and even beyond, we're trying actually to supplement the estrogen and even add on, which is by itself another increased risk. And unfortunately, when we're dealing with this disease, we are actually doing the complete opposite by blocking the estrogen. So it is a medication that does have side effects. And the good thing is we have become better about dealing with the side effects, trying to mitigate a lot of the repercussions, trying to try new medications. There has been a lot of integrative approaches to help with some of the symptoms. And that's the goal of any treatment that's given, is to try and help the patient be able to tolerate it so that they're not experiencing side effects lifelong. And the key within all this remains communication. Again, this is one of the hardest journeys. Breast cancer is one of the most treatable cancers. However, it has the most effect lifelong on patients, their caregiver, the woman herself, her image. And again, this is not like most people think. It's not like done and gone. It's something that a woman can deal with for years, even after her diagnosis. I think I wanted to conclude with this and leave room for our patient to take the lead on the rest. Thank you.
Thank you, Dr. Mina. Thank you, Dr. James. Now we'll turn our attention to Vanchelle so she can share a little bit about her journey.
Okay, I'm off of mute. I kind of had to mute myself. I'm at the elementary school, so please forgive my voice, because what I do. Hold on, I guess my video, okay, it's on. What I do all day long is I deal with little people, and as you can see, it causes me to have to yell a little bit more than I want to. However, I'm here, and it is a pleasure, it's an honor to be chosen to be a part of this. I am a 11-year breast cancer survivor, and for me, breast cancer hit a little different. I was only 26 years old when I was diagnosed with Paget's disease, which is a very rare form of breast cancer. Paget's disease is commonly known to be caused by high levels of estrogen and progesterone found in the body. And for me, it has not been confirmed. And I don't think it's a lot of research behind it. However, my doctors speculate that the exposure from birth control actually played a part in my developing breast cancer. I only had a stage 1. It was called, early on, my nipple began to be rashy, red, and draining a lot. And at the time, I was a college student, so I didn't have insurance. So I wasn't, I guess you would say, one that really ran to the doctor as soon as something, seemed to not be right, because I didn't have insurance. But as soon as I finished college and I set out to, get a job, I knew that I needed to make sure what was going on with me was, okay. I never thought it was breast cancer. However, I am a third generational survivor. It's not genetically linked, but my maternal grandmother, my maternal aunt, and then me, we've all survived breast cancer. In addition to that, my dad's mom and my dad's oldest daughter, which is my sister, also survived breast cancer. So breast cancer is very common in my family. But again, it wasn't genetically linked. I went in, I didn't have a tumor. So when I was 26 years old, which is rare, I had Paget's disease, which is rare, and there was no tumor associated. There was tiny calcifications that could be saw real clear on the ultrasound, and it had basically covered the entire breast. Paget's disease is not a rapid forming cancer. However, it did cover the entire breast, but it was still just at a stage 1, so it wasn't aggressive. I didn't have any chemo or radiation therapy. My doctors went from a perspective of basically removing the entire breast, tissue and muscle around it, to make sure that there were no more affected areas. And as of today, I've had 14 different surgeries. Because of not having insurance, I wasn't able to go in and have multiple things done at once. It was basically what I could pay for or what the doctors would agree to do at the time, being my financial situation. So what would have been maybe 5 or 6 surgeries for, someone with insurance, for me, it's been a series of 14 surgeries. I've had a bilateral mastectomy because I was told, eventually it'll develop on the other side. So I'm 26 years old. I just finished college. I have no insurance. And I have a 4-year-old, which her father is already deceased. So my take on it was, my child already has one deceased parent. Let's not make it 2. So I made a conscious decision to have a bilateral mastectomy, so I didn't have to sit and wait with it if and when it developed on the other side. As far as my journey, I wasn't married, so I did not experience a significant loss in relationship. So for some people, when I speak with them, they've lost marriages. A lot has changed within their relationship. I fortunately haven't, had to face that, but I did have to maneuver through a lot of depression, anxiety. To this day, I still fight, anxiety. It was a traumatic experience on top of the other traumatic experiences I've encountered. However, I do know that early detection saves lives. I didn't have insurance and I didn't go right away. However, I went and I did exactly what was asked of me. That was in 2012. Me, my oldest sister, and 2 of my classmates all fought in 2012. As of today, it's just me and my sister. Both of my classmates lost their lives, and a lot of it had to do with how they handled their diagnosis and how they decided to proceed with life. They didn't really take care of themselves in the beginning, so it came back on them. When it came back, it was a lot more aggressive. So by being more aggressive, unfortunately, they're not here with us today. I am an 11-year survivor. As of today, I am 38, and that 4-year-old daughter, which was 4 years old back when I was diagnosed, she'll be 16 in December. It has been a long, long journey, and it hasn't just affected me. She has been affected significantly. So if I can give any advice to anyone, understand your body, know when something's wrong, be persistent when you know there's something wrong. Whatever comes along with a diagnosis, if there's a diagnosis, take it serious. Basically align your life with what the doctors are asking you, and be mindful of the people that are around you that it also affects. Because my daughter is now back in counseling, due to one, she lost her father, and then now I'm learning that when I have to go to the cancer center, if it's nothing but my checkup, I just had an infusion, my iron levels are low, have a vitamin deficiency now. She can't stand to even hear the word cancer center, and I got an appointment. And I understand now better that she associates the cancer center with what's next. What's going to become of my mom? Is something wrong with my mom again? Am I going to lose my mom like my mom's friends, lost their lives? So it's a lot when it all boils down. I didn't have the chemo or the radiation. My oldest sister had the radiation, and it was very, very painful. My grandmother had chemo, and she got really, really sick. She's never been a diabetic. However, her body shifted, and she had to start using insulin. She started having heart problems. She got really sick, and they didn't think that she was gonna make it, so then they had to stop the chemo. So for everybody, it's different, but for the most part, your determination, to fight makes a difference as you go along that journey. And again, making sure you align your life with what the doctors are telling you at the moment so that you don't hit rough spots that you could possibly avoid. That's it for me. It has been an honor. It's a pleasure to be able to speak, and also learn more from what the physicians just said, because I myself within my community, I move around during October. I speak. I work with young people, and I'm one of the pillars within my community that advocate for breast cancer. So I had pageants, but the more I learn about breast cancer, chemo radiation, and just the cancer as a whole, it helps me be a better person within my community to advocate for this deadly disease that, if we're not careful, is going to continue to kill people at high rates. So that's all I have today.
Thank you so much, Monchelle, for sharing your story. It's so wonderful to hear that your daughter is 16 now. So thank you for sharing, and the importance of early detection and making sure that you know your bodies and know what's normal for you or what's not normal for you. I'm sure Dr. James and Dr. Mina also can express how important that is as well. One thing that you did mention, I know oftentimes people have questions about breast calcifications, and just wanted to open the floor if you, Monchelle, or Dr. Mina or Dr. James wanted to expand on that a little bit.
I'll let the doctors expand on it. For myself, I'm knowledgeable of it. However, I would love to hear, from their perspective. I've heard from a few physicians, but like I say, I'm always looking to be better educated.
I can take a stab at that. So I think a lot of times when we talk about breast cancer, we automatically think of a lump or a tumor. And I think Monchelle kind of explained specifically that sometimes it's not a lump that you're gonna feel, or something that's kind of, you know, hard and painful, which breast cancer can happen like that. However, a lot of times, what we see is what we call calcifications or abnormalities on imaging that actually tell us something is wrong. And that's kind of the whole benefit of, one, knowing your body. And Paget's disease is one of the, you know, rarest tumors. So it's good to notice anything as early as it's only a little bit of calcifications. And that's, again, one of the rarest tumors, but in a lot of other tumors, we do see as early presentation just calcifications. And our goal is to try and catch those tumors, if at all possible, before they actually become a lump. And unfortunately, a lot of times, not a lot of time, but in the younger patient population, and sometimes we don't have that opportunity or even that window. But I think, I mean, this is one way that cancer presents itself.
And I certainly agree with that. And, you know, one of the common questions that we get is, hey, you know, is it still mammogram? Shouldn't it be screening MRI? Shouldn't it be screening other imaging techniques? And no, the mammogram is still the standard because of being able to have a test that is really sensitive for those very small salt-like calcifications. That is what tips us off a lot of time to this very early pre-invasive kind of breast cancer. So that's why it's still such a very good and sensitive test for that, you know, a very reason.
Thank you both. Was there anything, Dr. James and Dr. Mina, that you wanted to follow up on, or add any details to before I open it up for Q&A from the audience?
No, go ahead.
Yes. If you have any questions, please put them in the chat, or any comments, please put them in the chat. You can also click the raise hand button if you have any questions for Vanchel or Drs. James and Mina.
And so there was one question, I did put the answer in the chat, but about one of our participants is about to do their simulation for radiation. And that is an appointment where you come into the radiation oncology department and we do a CT scan of you in the position that we're going to treat you in. And as I showed in my slides, we use CT scans to plan out and map out the radiation treatment. So we map out where we're going to treat, we map out what we're going to avoid treating, and then we prescribe and plan how we're going to give the radiation treatment. But they experienced, or from the surgery, a little bit of edema and a hematoma in the breast tissue, and just was wondering, hey, what can I expect with radiation with those things going on? And so my answer is that certainly those are issues that slowly improve and resolve just post-surgical recovery, which is why we typically plan to give you about a month from the time of surgery before planning your radiation. We do want you to be reasonably healed from the surgery before even planning, and certainly before giving the radiation treatment. However, because edema specifically is something that can wax and wane kind of chronically after treatment, we do expect for you to see a bit of fluctuation of that during the radiation treatment. It wouldn't be something that usually keeps you from starting. And the same thing with the hematoma. It could just take a little bit longer to resolve, but as long as it's improving prior to starting, typically we don't push out your treatments significantly before initiating the radiation treatment. And then for edema, if you have been referred to a physical therapist, which a lot of times we do to make sure that you understand techniques like massage and stretching to help with post-surgical and post-radiation issues, then we want you to just keep following with them and do their recommendations. And periodically, it's not uncommon that you might need to check back in with physical therapy down the road just to make sure that as your body changes after treatment and as you have issues, that they're there to give you recommendations years down the road as well.
Thank you, Dr. James. I don't see any questions or comments in the chat. And if you have any last minute questions, comments, please stop me. But I wanted to say thank you again to Vanchel for sharing your story with us and sharing your journey with us. We're so happy that you're here with us today and that you're with the kids at the elementary school and still found time to share your story. We're so appreciative. To Dr. James and Dr. Mina, thank you so much for sharing your expertise and your knowledge with us.
Thank you.
Thank you.
Thank you so much.